Metoprolol versus Atenolol. A 64-year-old man with hypertension and angina is started on a beta blocker. His blood pressure and heart rate improve, but a few weeks later he complains of disturbed sleep and vivid dreams. His doctor considers switching him to another cardioselective beta blocker. So, when should we choose metoprolol and when might atenolol be a better option? The answer lies in some important differences between these two commonly used beta-1 blockers. Mechanism of action similarities. Both metoprolol and atenolol are cardioselective beta-1 blockers. At therapeutic doses, they have little effect on beta-2 receptors and therefore carry a lower risk of bronchospasm than non-selective beta blockers such as propranolol. Their beta-1 blockade produces three major effects. First, they decrease heart rate, producing a negative chronotropic effect. Second, they decrease myocardial contractility and cardiac output, producing a negative inotropic effect. Finally, beta-1 blockade in the kidney inhibits renin release, reducing renin-angiotensin-aldosterone system activity. Together, these actions contribute to a reduction in blood pressure. Mechanism of action differences. Metoprolol is lipophilic, so it readily crosses the blood-brain barrier. This explains its greater tendency to produce CNS effects, such as sleep disturbances or fatigue. It undergoes mainly hepatic metabolism. An important point is that dosing depends on the formulation. Metoprolol tartrate is commonly given twice daily, whereas extended-release metoprolol succinate can be given once daily. In contrast, atenolol is hydrophilic, resulting in poor CNS penetration and fewer central side effects. It is primarily renally excreted, therefore, renal function becomes important when atenolol is prescribed. Longer duration allows once daily dosing. Adverse effects similarities. Both can cause bradycardia by reducing heart rate and hypotension by lowering cardiac output and blood pressure. Excessive suppression of conduction through the AV node can also produce AV block. Both drugs can also mask some warning signs of hypoglycemia, particularly tachycardia. However, this effect is generally less prominent than with a non-selective beta blocker such as propranolol. Fatigue may occur because of reduced cardiac activity. Adverse effects differences. Because metoprolol is lipophilic and crosses the blood-brain barrier, it is more likely to produce CNS effects, including fatigue, sleep disturbances with vivid dreams, and sometimes depressive symptoms. In contrast, atenolol has poor CNS penetration, so central adverse effects are generally fewer. However, because atenolol is primarily eliminated by the kidneys, it can accumulate in patients with renal impairment, making dose adjustment important. Shared clinical uses. In hypertension, both lower blood pressure by reducing cardiac output and renin release. In angina pectoris, they decrease heart rate and contractility, thereby reducing myocardial oxygen demand. They are also used post-myocardial infarction, where beta blockade provides cardioprotection by reducing cardiac workload and the risk of arrhythmias. Finally, both can be used for rate control in supraventricular arrhythmias, where slowing conduction through the AV node helps control the ventricular rate. When to prefer each agent. Metoprolol may be preferred when CNS effects are not a major concern and a hepatic route of elimination is advantageous. Importantly, metoprolol succinate is one of the evidence-based beta blockers used in patients with heart failure with reduced ejection fraction. Atenolol may be considered when fewer CNS side effects are desirable because of its poor penetration into the brain. Its once-daily dosing may also improve compliance. However, because atenolol is eliminated mainly through the kidneys, renal function must be considered, particularly to avoid drug accumulation in renal impairment.